From the American Academy of Pediatrics.
When it comes to caring for adolescents and young adults, confidentiality is essential.
New policy from the AAP offers ways we can respect our patients' privacy while also keeping them safe.
Part of our role as pediatricians is to support young people in actually engaging their parents more and sharing more information over time.
Plus, new research in the Journal of Pediatrics shines light on what parents think about the neonatal intensive care unit.
Things that they brought up, specifically wanting better communication around the reasons for admission for their infants, and then also to explain the technology that's being used in the NICU.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about maintaining confidentiality when treating adolescents.
Because we're often talking with other pediatricians, we don't like to give out many parenting pearls, but I have one, David. Always check what's in your garbage, particularly in the kitchen. That's how I find out when my kids don't eat dinner or are having unsanctioned snacks. There is a wealth of information in what they throw out.
Oh, Joanna, this is only the start, because I'm going to add that our kids were so well trained to recycle that's how we knew when they started drinking. They still put the empty bottles in our own blue recycling bin.
That is truly a teenage parent problem, and I really do hope I'll know if my kids are doing anything unsafe at that age. At the same time, I do want them to build a sense of autonomy. It sounds complicated, David, is it?
Oh, Joanna, it is. And as pediatricians, we're often caught in the middle between ensuring teens trust us with the information we need, while at the same time encouraging family involvement and open communications. Luckily, we do have some guidance today, courtesy of Dr. Richard Chung, a friend of mine from North Carolina who last joined us for episode 111 to talk about youth mental health.
Of course. Dr. Chung is a professor of internal medicine and pediatrics in the Division of General Pediatrics and Adolescent Health at the Duke University School of Medicine, but he's moving up here to Philadelphia. Richard is lead author of the AAP's new policy statement and technical report, Confidentiality in the Care of Adolescents. Dr. Chung, welcome to the show.
Thank you, Joanna. Thank you, David, as well. Really appreciate the invitation to come back.
Well, we love having you. Now, Richard, every child matures differently. Who are the patients we're thinking about when we say adolescents?
So it's a good question, David. So adolescents are defined a little bit differently depending on who you ask. Now, generally 11 and up, 12 and up is kind of that lower threshold. And then, within the AAP, we like to think up to 20, 21, thereabouts, in terms of young adulthood. Now, when we talk about confidentiality, it's not just that broader adolescent young adult age range. It's the legal aspects of the age of majority. So typically age 18, although that actually varies in certain jurisdictions. But thinking about what we would call minor adolescents, so teenagers, youth who are under that age of majority, but also young adults 18 and up for whom confidentiality also is a relevant topic. And so, it's really a great opportunity to elevate this issue because confidentiality, as you both know, is really a bedrock of adolescent young adult care. And particularly in our modern context, it's really important for us to double down on this and really clarify what does it mean and how do we protect it.
I'm curious about some things you said, and specifically this modern context that we now live in, because with more use of the electronic health record and virtual visits, are we seeing more breaches in adolescent confidentiality than in the past? And is that what inspired you to write this?
Yeah, it's a great question. I do think the contemporary technological environment is a big motivator for really clarifying the situation, the evidence base, and the complexities that we all have to kind of reckon with in the modern environment. Again, confidentiality is not a new issue. It's been well recognized as a critical foundation for adolescent care for really decades. And the AAP has long been an advocate for the importance of confidentiality, but we as an academy haven't actually formally discussed this in one of our policy papers since really the early 2000s. Now, it's come up certainly in other documents about particular health issues, but there hasn't been something dedicated to confidentiality in that many years. And as you know, practice has changed. The core principles haven't changed, but electronic health records and other technological facets, evolutions in terms of the socio-political context and kind of the legal context within each state and jurisdiction, those things have changed. And so it's really critical that we examine what the situation is. And also, there's been an accrual of evidence, research evidence to demonstrate the importance of confidentiality in terms of access to care and clinical outcomes for these patients. And it's important for us to summarize that evidence so it can be applied in practice.
You know, as critical as that confidentiality can be to protect our adolescent patients, we've also talked before about those situations where sometimes we have to actually break the confidentiality to protect our patient's health or even life. But let's review, what are some of those situations and how do we know?
One thing we always say, even as a staunch advocate for the importance of confidentiality, is that confidentiality is never absolute. And I also say that confidentiality is never the highest order priority. It's actually the health and well-being and safety of the youth. Now, confidentiality most often is a means to that higher order end, but sometimes confidentiality doesn't fit. It's not consistent with ensuring the safety and well-being of a young person. And so in those less common scenarios, it's usually my judgment as a clinician or your judgment around the safety of that young person, whether it's a concern for harm to self or others, whether it's a concern for abuse or neglect, or some other scenarios like reportable diseases or certain legal proceedings where confidentiality may not be maintained. And so there are exceptions to the rule, and it's really important that we keep those in mind.
And when you encounter one of those exceptions, and you do have to involve other people in an adolescent's care, maybe even against their wishes, how do you frame that for the involved patient?
I think that's one of the greatest challenges for practicing clinicians. We often have this fear that if we breach confidentiality, that's going to undermine our relationship, that's going to make it harder to care for that young person the next time. And those things may be true depending on the situation. But again, our highest order principle is always ensuring the safety, at the very least, the safety of the young person, and moving them towards higher ground, a healthier and safer place. And very often that does require involving a caring adult like a parent or a guardian. And so when you get to the point in your clinical judgment where a disclosure needs to be made, the first order principle is to, number one, come to that determination using your expertise and your clinical judgment. The second piece is then involving the young person and offering them as much control over that process of disclosure as possible. Who are we going to talk to? What information will be disclosed and what could be preserved and protected? Who's going to make the disclosure and how is it going to be made? All those process elements are actually quite important for a young person. And to be honest, in the many situations in which I've had to make those disclosures, young people often are quite willing partners if you work with them, if you discuss the details with them and give them the control over how those disclosures are made.
You mentioned parents when you were talking, and parents of teens are worried that they'll be kept in the dark about their children's health. How do you encourage young people to involve their families in sensitive medical situations?
I think it's a great question. As a parent myself, I have some level of discomfort with this idea that my teenager might be having a really important conversation with another caring adult and I'll be maybe completely oblivious to that. And that's just the reality. Or that I might only have part of the story. That doesn't feel great as a parent. Now, as a clinician, I understand why it's important that we preserve that avenue so that if my teenager, let's say, needs help, they have an easier mechanism to get to that point. That's different than having to come to their parent, which, as we know, for teenagers is often not a very easy thing to do. And that has nothing to do with how much they love us and how strong our relationship is. It's just that our identity as parents makes it sometimes hard for us to be the first stop in that pathway to getting better. One of the things that I always point out to parents who have some discomfort with confidentiality is exactly what you're saying. Part of our role as pediatricians is to support young people in actually engaging their parents more and sharing more information over time. But it's important that teens are supported to do that in a way that is gradual and comfortable to them. And very often it starts with that full confidentiality where they're asking their curious questions of their pediatrician without fear of disclosure, fear of reprisal. And then the pediatrician then is in a great position to help coach them on how can I raise that with my parent? How can I ask my own curious questions at home so that I don't have to entirely rely just on the pediatrician? And pediatricians are quite effective in helping teens make that transition to increased engagement of the parent. And, when the parent's in the room and the one who's kind of bearing down and asking the question, it's really hard for teens to kind of rise to that occasion. They really need somebody else to help them and coach them. And that, at the end of the day, is what the parent wants, is increased communication with their teenager.
I love that. Richard, I know that both you and I have had to adapt to some recent changes in North Carolina's laws around adolescent confidentiality. How much do these statutes vary from one state to another, and how can we as pediatricians keep up with them?
It's a great question, David, and I think it's part of the complexity and challenge of this domain. Confidentiality is derived partly from federal statutes, so federal laws that apply to all of us. But then there are state-by-state differences in terms of how those laws actually play out. And I think those differences can be confusing, certainly. If it is one way in North Carolina, where we are, and then is totally different maybe just across the border in another state. And so it's really important for clinicians, wherever they are, to know what are the laws and rules and regulations that apply to me in my setting. Confidentiality is never about going outside of what's allowable, certainly. Hopefully that's obvious. Hopefully that doesn't need to be stated, but it's a good reminder. So you should know what applies to you in your particular setting and abide by that. Within those bounds, trying to optimize the sense of safety and access that young people get within your practice.
And there are some teens who might be more dependent on their parents and others who don't have parents as primary caregivers. In these special situations, how do we maintain confidentiality? Do you have any examples of that?
Joanna, you raise a really great point that confidentiality is not just complicated because the rules vary from state to state. It's also complicated because not all teens are the same and not all circumstances are the same. And our technical report in particular, which is this broad literature review, actually goes through a variety of these different scenarios. Now, a couple examples come to mind. One is young people who are neurodiverse, who have developmental differences. Now, what does it look like to preserve their confidentiality as they move through the teen years and become adults themselves? Now, a lot of that comes down to discussion with the patient, with their family, really thinking through what makes the most sense. Again, with the idea that confidentiality is a means to an end. The highest order end is beneficence, right? It's an ethical principle of doing right by the patient and ensuring their health, well-being, and safety at all costs. And so that might look different, and confidentiality might be a different tool and resource depending on each different situation. We also have some discussion of young people in foster care, young people who are involved in the justice system, young people who have different immigration experiences. So it's actually quite complicated, and it's part of the beauty of pediatrics is that we care for this rich diversity of kids and youth. But it is challenging from a clinical standpoint to really think through how do we apply it for their particular situation.
Well, Richard, this is such a critical policy statement and technical report that we want everyone to go read them. But before they do, what takeaways do you want to leave our listeners with?
I appreciate that opportunity, David. I think two things come to mind. One, for us as clinicians, is just a reminder of just how important confidentiality is, that we know through robust research evidence that it makes a huge difference in terms of how young people access care, and also once they're in the office, how forthright they are in talking to us. And of course, out of that comes how well we can care for them, the quality of their care, and then the outcomes. And so it's really important, and yet we all know it's really hard to do in practice. And so I myself, even as a confidentiality advocate, often feel tired by it because you have to go through so many other steps. There's a lot of extra work that's entailed, but it's worth it. And so just kind of an encouragement there that our teens are relying on us, and it's important that we go that extra mile to ensure that we preserve their confidentiality. The other thing I'll say is for people who are in suits making decisions about healthcare systems and policy. You have a role to play here as well. Part of the reason why it's so hard for Dr. Hill, let's say in practice, to preserve confidentiality for the team that needs it is because our systems and structures aren't formulated to preserve confidentiality. So Dr. Hill has to go through all sorts of other extra steps to preserve confidentiality. But we can make improvements. So if somebody is designing EHRs, there are steps that can be taken to improve what we call data segmentation, making it easier to parse in the electronic data what's sensitive versus not. If somebody is overseeing a health system, there are other steps you can take to ensure high quality training for team members. If somebody's in a position of making health policy, there are steps that can be taken in that domain as well. And so the technical report and the policy statement are for all of us, everybody who has any skin in the game in terms of the care of young people, not just for clinicians like us.
I know now everybody's going to go read those reports. Dr. Richard Chung, thank you so much for joining us today.
Thank you, Joanna. Thank you, David. It's been a lot of fun.
To read the policy statement and technical report, Confidentiality in the Care of Adolescents, go to aap.org/podcast.
Coming up, we'll look at the perspective of parents whose infants spend time in the neonatal intensive care unit, or NICU.
David, when you think of the NICU, what kinds of patients come to mind?
Ooh, very, very small ones with lots of little tubes and wires.
A lot of people think of premature infants, and of course, the micro-preemies are such an interesting patient population. But the majority of premature infants I care for are moderately preterm, meaning they're born between 32 and 36 weeks. And once they get close to 36 weeks, I like to call them the great pretenders because they might trick you into thinking they don't need the NICU at all.
Oh, yeah. In Goldsboro, we often take back transfers from neonatal ICUs at 34 to 36 adjusted weeks. And others in that range are born in Goldsboro and just stay there in our special care nursery. And they can definitely have some NICU issues that linger with feed, sleep, other things. So I'm not surprised you call them pretenders because some do a very bad job of acting like their term, even when they correct to it.
That's why I'm so excited to have Dr. Ashley Osborne on the show today. She's a neonatologist and an assistant professor of pediatrics at the Medical University of South Carolina and works at the Shawn Jenkins Children's Hospital. We don't often mention where people did their fellowships, but Ashley was a fellow at Children's Hospital of Philadelphia, and I had the pleasure of being her clinical mentor, so I'm super excited that she's on.
So excited, in fact, that I don't think we mentioned why she's here today to talk about the paper Enhancing NICU Care and Communication, Perspectives of Moderately Preterm Infant Parents, of which she's the first author. Dr. Osborne, welcome to the show.
Thank you so much. I'm so excited to be here, and it's wonderful to be reunited with you, Joanna.
Yes, it's wonderful to be on the airwaves with you. And I know not everyone spends their time in the NICU. Can you give our listeners an idea of how many infants are born premature and might fall into that moderately preterm category?
About 10.5% of infants are born preterm or before 37 weeks gestation. Around 85% of infants born premature are actually moderate to late preterm babies, and this means that they are born between 32 weeks and 0 days to 36 weeks and 6 days. It can be a little confusing looking at the literature that's out there because people use different cutoffs for moderately preterm and late preterm. But in general, the most widely used definitions are for a moderately preterm infant, this is a baby born between 32 to 34 weeks gestation, and a late preterm infant would be born between 34 to 36 weeks. And so for this paper, we defined moderately preterm as babies born between 32 weeks and 0 days to 34 weeks and 6 days, because babies born under 35 weeks automatically get admitted to the study site NICU.
So we're actually talking about a lot of babies. How do their outcomes differ compared to infants who are very or extremely premature, or in other words, less than 32 weeks?
Yeah, so in general, their outcomes are really good, which is great. But these babies are still at higher risk compared to term infants for respiratory problems, rehospitalizations, and long-term neurodevelopmental differences or behavior differences.
So you did qualitative interviews for this paper. What families did you approach and what sort of questions did you ask them?
So we approached birthing parents of infants born between 32 weeks and 34 weeks, 6 days. We invited parents sequentially to participate in our study, and we developed an interview guide using family-centered care as a shaping concept, and then asked them questions really about their NICU experience. And we focused on questions surrounding their knowledge about their infant's condition, their discharge preparedness, and what their communication preferences were, and how that aligned during their NICU admission with the information they received from the medical team.
And with all that, what did you find? Are there unique ways that we could be supporting this big NICU population?
From our qualitative interviews, 4 themes emerged from talking with the parents. The first theme was feelings of care team connectedness and inclusion. In general, parents felt pretty connected with their care team, and this was largely due to the bedside nurses. The second theme that emerged was that parents were really confused about the NICU admission and the care that their infants were receiving daily. The third theme was around discharge readiness, and overall parents felt prepared for discharge, which was wonderful, but they felt that that discharge date was really a surprise to them, and they wanted more lead time so that they could prepare their home and mentally prepare to take their baby home for the very first time. And then the final theme was around their communication preferences, and parents identified that there was value in in-person communication, but also electronic communication methods. So they reference things like wanting to use a mobile app, the internet, email, and texting to continue to receive information from their care team about their baby.
I think this hits on kind of all 4 of those themes, but were there specific things families mentioned that might improve family-centered care in the NICU?
Yes, and that's why this study I feel is important, and it was really fun to take part of because we heard ideas and things to benefit the families we take care of straight from the parents. And so things that they brought up, specifically wanting better communication around the reasons for admission for their infants, and then also to explain the technology that's being used in the NICU. It's often, common for us, we see it every day, but the monitors, the incubators, the alarms, they're all new to families. So they mentioned that they really needed more education surrounding that.
Is there information that you got out of this study that could translate to how general pediatricians care for these babies after their discharge?
Yes, that's a great question. I think it's really important for pediatricians. For families who have a moderately preterm infant, their NICU course may have been relatively smooth from our standards, and they may not have encountered many complications, but families still likely felt that the admission was stressful, and they may have feelings of anxiety being home with their baby for the first time. And so that's where general pediatricians can really step in at those first appointments and give them good anticipatory guidance and maybe go over some lingering questions that parents still have from the NICU. Specifically, families brought up that they would benefit from some further follow-up after discharge from the NICU. They felt, that they were, quote unquote, on their own for the first time after they had a whole team of medical professionals taking care of their infant for weeks. And a couple topics were of big concern to families when they first got home. So general pediatricians could focus on talking with families about reflux and routine infant care parents still had questions about, as well as they were really nervous about apnea of prematurity and if their infant was having a normal breathing pattern at home.
Well, those are some great tips for general pediatricians to think about when they're seeing these patients. And Ashley, do you have any last takeaways you want people to know about caring for moderately preterm infants in the NICU?
I think the biggest thing is that these babies really haven't been the study of much research, these infants and their families have not been the center of much neonatal studies, and their care has really been extrapolated from extremely or very preterm infants or full-term infants, and they're neither. So we need more research on these moderately preterm infants, and I think there is growing interest in focusing on these babies and their families. And I think a big takeaway just from qualitative research in general is that talking to families is so important, and hearing their experience through their own words, we can get great information.
Well, Dr. Ashley Osborne, now I know why Joanna was so excited to have you on. This was such a pleasure. Thank you for joining us today.
Thank you. The pleasure was all mine.
To read the paper, Enhancing NICU Care and Communication, Perspectives of Moderately Preterm Infant Parents, go to our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, as you know, I just came back from another trip to the American Academy of Pediatrics headquarters, and I know this is corny, but I am always so inspired. From the little statue of the dancing children out front to the incredible work that people are doing in that building every day, it just kind of recharges me in my own career to go up there and see how hard everybody is working to make sure that children get what they need.
It's just like a beautiful building too. It's just like gorgeous there. So my Say Ah is about the baby, because that's kind of all I think about now. And she's in the 4-month range, and I love when they start to roll and she can kind of get to her side. She can throw her butt over, and she can't quite move her head, which I just think is really funny. She's just throwing her butt up and almost rolling over. But to watching those developmental milestones, that's always a good Say Ah for me.
This is always amazing, isn't it? They're just look what you can do.
Yeah, and babies myelinate head down and inside out, and I just love watching that too.
I love that.
That's so fun.
Babies rolling, you're watching myelination. We're such geeks. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at ways to protect families from so-called forever chemicals.
We'll talk to Dr. Alan Wolf about the prevalence of PFAS. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.